Good evening, everyone. I'm Caroline Handley, Workforce Development and Systems Coordinator from Murray PHN. I begin by acknowledging the traditional owners of the lands on which we meet this evening and pay my respect to their elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people. I'd now like to introduce our presenter, Dr. Peter Eisenberg. Peter is the Director at Doctors of Ivanhoe, a member of the AusVaxSafety Advisory Committee at the National Centre for Immunisation Research and Surveillance, a member of the Immunisation Coalition, a member of the Influenza Specialist Group, and a former Executive Director of the North East Valley Division of General Practice. Thank you, Peter.
Thank you very much for that lovely invitation and for having me tonight to present to you. Just customary to begin with the first to mention that potential conflicts of interest are minimal, only that I receive payment for my time and involvement and have no ownership of any shares or other forms in vaccine or pharmaceutical research. And I've been involved as a GP advisor on a number of committees and a member of national immunisation committees around the country. Tonight we've got a very challenging topic to cover, and that's the recent changes that commenced on the 1st of July to the National Immunisation Program that mainly involve pneumococcal, meningococcal and hepatitis A vaccination. It introduces to the National Immunisation Program the meningococcal B vaccination and changes to the ACYW. And for hepatitis A vaccination affecting states other than Victoria that are relevant, that come in line with the meningococcal B changes, and so we'll just mention them so that you're aware of those and the reason for them. And the probably most significant and immediate impact of the pneumococcal vaccination schedule changes that impact both on our current recalls and reminders that we may have in place for people for existing vaccine recommendations that we've made that require now a change and some strategy to approach that, and also the complexity of the schedule. Things are very different now in a lot of ways, and it's important that we stay focused on important areas that we can still make impact of reducing vaccine preventable diseases. So with regard to flu, this is the latest update from the flu surveillance in Victoria, and it shows in the black line 2020, a strange year for flu as it is for everything else. This is the 2020 compared to other seasons, and you can see that our activity for flu is very low, reflecting the social distancing that we're doing and all the strategies to prevent coronavirus, and we've successfully reduced the amount of flu. And those of you familiar for tracking the actual confirmed cases of flu, influenza every year, and alongside of other respiratory viral pathogens, we've never seen a chart like this before. So things are very different. Tonight we're going to try and stay focused on these important changes, the overview of the technical advisory group on immunisation that lead to the meningococcal vaccine changes, the pneumococcal changes, and most importantly, once we get our heads around that, how do we implement these changes in our practice? And we'll finish with a couple of case studies. The references, usually this is a simple list of including the references and how you can source them so that you don't need to take copious notes tonight. The meningococcal references are across 2 documents, and this was part of a suite that was sent to us just before the 1st of July by the government. This is the National Immunisation Program information sheet, and this is the ATAGI technical and clinical advice that refers to it. We received in that suite not just the 2 meningococcal references, but we received 2 parallel pneumococcal references, also by the National Immunisation Program and the advisory group to support it. And the Chief Health Officer, in his wisdom, sent round an additional sheet for the hepatitis A changes, and that's very important. We're very grateful to have all of these references to help us understand the changes. That wasn't the end of it. There's more, because there was another sheet to present the perspective of the changes from the point of view of older non-Indigenous adults, as well as people with risk conditions, and of course Indigenous people and the impact. So this suite of 8 documents all landed on our desk, and so I thought, beaut, we won't need to do any updates because it'll all be self-evident from these summaries. Unfortunately, the more summaries you have, the more guides, it can increase the complexity further. And indeed, to clarify the guides, this slide just shows the pneumococcal references with those 2 sheets I referred to before. An additional sheet was included for the what's called the clinical decision tree. To help explain all that, the National Centre for Immunisation Research and Surveillance brought out 2 lengthy documents, one being the background and of the pneumococcal vaccines for Australians, and then frequently asked questions were 12 pages to help answer the questions of clarification. So to simplify it, the Immunisation Coalition added information sheets and the Melbourne Vaccination Education Centre. So we now have a flood of information to try to deal with. The good news is that by the end of the evening, I'm hoping that everybody will be familiar and fluent with the changes and be able to handle all of the recommendations, certainly for pneumococcal, just off this one double-sided sheet that was included in the Chief Health Officer's suite. And we'll come back to detail these. This demonstrates the schedule for pneumococcal and the indications for people recommended to have it under the new changes. So for a physical list, this top 2 groups are what we received in that mail out to all vaccine providers in July, just prior to the commencement. And these additional references are where you can go to for further fact sheets and information. Naturally, the Immunisation Handbook is the ultimate resource for us to refer to during our practical sessions. The Victorian Department of Human Services immunisation schedules, and they are important for us to refer to. And the Melbourne Vaccination Education Centre helps support us with guides as well. And the Immunisation Coalition has, in addition to its simplified charts, they have the very practical PneumoSmart website. This is still not yet functional for the 1st of July changes, but is a very practical guide for when you have trouble finding out the right one to implement. Here we have the DHS immunisation schedule for Victoria for the infants and children. And just to show you for the routine vaccine schedules for both pneumococcal and meningococcal, we see that it's a very important element of our routine immunisation, and the new changes replace or enhance. Not for pneumococcal in children, we'll see they stay the same, but meningococcal, this new one added. And at the other age groups for 12 months of age and children with particular risk groups, we see the additional time points. We'll go through these in detail in a few moments, but just to show you what our schedule looks like and how to find it. This is all updated from July 2020. So if anybody has a Victorian schedule predating that, please replace it with the current schedule. It is significantly different. also for adults and for people with special risk groups. We're going to step through all of those, so don't be alarmed. Naturally, if anybody needs to adjust themselves, collect the mask. I feel like this a couple of times a day still, but I'm gradually getting used to it. Possibly a glass of wine might be what you need to get through the rest. So we're going to dive in with an overview of the recommendations to get our minds around the changes and then the detail of the changes. So the National Immunisation Program schedule changed to improve protection against both meningococcal and pneumococcal disease in consultation and advice by the ATAGI group, which is who writes the handbook. Changes to the meningococcal schedule involve two main elements: the meningococcal B element, where Bexsero will be added for the first time to the National Immunisation Program for all Indigenous infants at 2, 4 and 12 months of age. So we're just talking here for Indigenous infants on the National Immunisation Program at 3 time points in infancy. An additional dose at 6 months is required for Indigenous infants who have specified medical risk conditions, which we'll identify in a moment. Introduction of the vaccine is supported by a catch-up program for all Indigenous children aged under 2 years until 2023. So catch-up can occur over those 2 years. Meningococcal B and meningococcal ACYW vaccines will also be funded under the National Immunisation Program for people of all ages with specified medical risk conditions that increase their risk of invasive meningococcal disease. We'll look at that chart in a moment. The changes to the Hepatitis A vaccine schedule are mainly to accommodate the introduction of the new meningococcal B vaccine for Indigenous children. And you'll see the practical reason why that makes very good sense to do. And it affects children in Northern Territory, Queensland, South Australia and WA, doesn't involve Victoria, but important for us to be aware of. And the changes to the National Immunisation Program for pneumococcal vaccination are very significant. They change, the recommendations change in relation to vaccine dosage and timing, and they've been updated for adults and people with conditions that increase their risk of disease. And there are no changes to the universal infant schedule for the 13-valent pneumococcal conjugate vaccine. And you will see this when we examine the schedule in a moment. The list of conditions that increase the risk of pneumococcal disease has also been revised and simplified. I'm not sure if we'll all be in agreement about simplified as we move through it, but at the end I hope that's the case. So in detail, meningococcal vaccination. For this section, we'd be referring to the two advisory sheets that came around in July, and all the information you need for it is contained in there. There's the explanatory couple of pages followed by the important chart that identifies meningococcal vaccines alongside pneumococcal and Hib for people with high risk of these conditions. However, while we're focusing for this part of the talk on the meningococcal vaccines, it's important that the fine print is closely examined. It's in this fine print that we understand what this chart, how to apply this chart. So a tick in this chart means that for this condition, that vaccine is recommended. A shaded part of the chart means that the vaccine is funded on the National Immunisation Program. So where ticks appear without shading, that means they're recommended but not funded. And a key element of all these changes is identifying there are significant gaps between what are recommended across the suite of changes and what are funded of them. and we'll tease that out in a moment. So here are the conditions that identified people at higher risk and recommended to have meningococcal vaccines. And where they're recommended to have meningococcal, it means the meningococcal B vaccine and the ACYW. There are a couple of indications where there's special asterisks that you refer down here, where they're funded, where, for example, in certain conditions, where they need to have met the criteria listed here. Just to remind you about meningococcal vaccination and the importance of it, invasive meningococcal disease is a serious bacterial infection caused by Neisseria meningitis. The most common causative serogroups are A, B, C, W, and Y that affect human disease. Invasive meningococcal infection often causes septicemia and or meningitis and is most common in children under 2 and adolescents aged 15 to 19. And the rates of carriage in the nasopharynx are highest in older adolescents and young adults. So here is the notifications, that's incidence of meningococcal disease in Australia across the different age groups. And you see the very high peak in young children and another peak in adolescents, and death rates for meningococcal disease, including septicemia, show the very high disease burden amongst the very youngest people. Currently, following vaccination already for meningococcal C, meningococcal serogroups B and W are currently the groups that cause the most disease in Australia. And that is in children, adolescents and young adults. Meningococcal disease caused by serogroups W and Y occurs over a more diverse age range and can present less typical clinical manifestations than traditional meningococcal that we see with other serogroups C and B. Here are the annual cases of the different serogroups of meningococcal, and you can see in green the meningococcal C proportion has reduced to being almost eradicated following the introduction of meningococcal C vaccine over the last couple of decades. But you can see this brown colour, the meningococcal B, has remained a very high proportion and high numbers, even though the overall rates of meningococcal disease have fallen over that time period. And in purple, meningococcal strain W has really worried at the increase, both W and Y, but particularly W. And you can see we're hoping we're seeing an impact following the introduction of the conjugated ACYW in the last couple of years, and let's hope that trend continues. And that's part of the strategy for what we're doing. There are 3 basic meningococcal vaccine types. That's the ACYW conjugated vaccine, the meningococcal B, and of course we've had meningococcal C alone in combination with Hib for the Meningitis and alone as a monovalent vaccine over the last few years. But these are now the vaccines that are current, and the different age incidence for the licensed vaccines that exist, including Menactra, Menveo and Nimenrix for the meningococcal ACYW. And Nimenrix is the brand that is funded in Victoria through the National Immunisation Program at 12 months of age and in adolescents aged 14 to 19. The other 2 vaccines are not available through the NIP, but are available through private prescription. The classification of the meningococcal vaccines have shown evolution back in the time where you'll recall there were a couple of other polysaccharide vaccines that we don't use anymore. The improved quadrivalent vaccines are these, with Nimenrix funded in the program, and Bexsero and Tremember being the meningococcal B vaccines, with Bexsero being funded in the program. So therefore, for meningococcal, the Nimenrix will be funded from the 1st of July for all people of all ages, with the following conditions: functional or anatomical asplenia, including those specific groups, defects in complement components affecting those groups, and current or future treatment with eculizumab, the monoclonal antibody that some people may be treated with. And there are no changes to the Niemann-Ricks routine schedule for toddlers at 12 months of age or adolescents at year school 10, age 15 to 19. For meningococcal B, for Indigenous children, as we mentioned before, 2, 4 and 12 months of age. Of course, the 2-month schedule is now given from 6 weeks of age, as that's the earliest it can be given, and the earlier we protect with these vaccines and the other routine schedule vaccines, the better. So 2-month vaccines read 6 weeks. Indigenous children under 2 should receive catch-up Bexsero for a 2-year period till 2023. And the number of catch-up doses depends on the age of commencement. I'll come to that in a sec. Bexsero is the only vaccination that requires paracetamol use because of common side effect of fever following the vaccine, and preferably to be given 30 minutes prior to the Bexsero dose or as soon as practicable afterwards, and then followed by 2 further doses at 6-hourly intervals regardless of the presence of fever. Healthcare workers are responsible to ensure that everyone receiving a service is asked the question, are you, or is the person for which the vaccine is intended, of Aboriginal or Torres Strait Islander origin, to confirm they identify as Indigenous and therefore eligible for the Bexsero program. And please don't forget to report the vaccine doses to the Australian Immunisation Register. Here's that chart again with the focus for meningococcal vaccines bordered in red, the conditions for which ticks appear indicate that vaccine is recommended for that condition, and where there is no shading, then the condition does not make the person eligible for funded vaccine. Those fine print details are very important. Just looking at where meningococcal B therefore fits for Indigenous people at 2 and 4 months. This is our routine schedule updated for July for Victoria, and at 12 months, both the meningococcal ACYW and standard vaccine, universal vaccine, and for all children, and the meningococcal B for Indigenous children. And of course, for adolescents, at those 2 age, at the year 10 or equivalent age equivalents, 15 to 19 years, and that's funded for universal for all children, adolescents at that time. Adults in special risk groups, where they have these conditions that we just discussed on that slide, here's how they appear on the Victorian immunisation schedule. I mentioned that the number of doses required for meningococcal vaccines in this chart for ACYW, this chart is in the handout that was given to us. It's a complex schedule. So you can see for ACYW from 12 months of age, only 1 dose of Niemann-Ricks is required from that age onwards. Younger ages where the vaccine may be given earlier requires different brand and different numbers of doses. And for meningococcal B, almost as complicated a schedule as well for people at not increased, without any medical indication for increased risk, and this column for those with indicated to have extra doses. And you can see from there, from 12 months of age, people without any increased risk require 2 doses 8 weeks apart. As part of the introduction of the meningococcal B to Indigenous children, there would have been a clash with the hepatitis A schedule in these northern states in Australia if the hepatitis A vaccine was not changed in its timing. So we refer to the hepatitis A clinical advice sheet, and we see this instruction that in those states where it's affected, where hepatitis A vaccine is routinely given, it will move from 12 months to 18 months, and the second dose from 18 months to 4 years of age. And that change will facilitate the implementation of the program for Indigenous children, and by moving it, it means that they reduce the number of vaccines scheduled for administration at 12 months and would otherwise complicate it in those states. It doesn't affect Victoria, but it's there for your reference. Now we move to pneumococcal vaccination changes, and we refer firstly to the two sheets that the two groups of sheets that the Chief Health Officer provided to us, but it's important that we focus on extra elements to supplement our understanding of it. At the end of the night, we'll only need to refer to this double page, and we'll see why now. That double page has on the front the clinical decision tree that gives 5 different schedules according to the individual's risk for pneumococcal risk. And on the flip side is the updated table for the conditions, the different ages for eligibility for NIP recommendations, and for the and for funding. So just to explain, this chart is read differently from the purple equivalent we looked at before. This is a potential area of confusion amongst people who are looking at this information. I'll clarify it this way. If the condition is listed on this left column through here, then they are recommended to have pneumococcal vaccination as a high-risk condition in the new suite of changes from the 1st of July. But they only are eligible for a funded pneumococcal vaccine if they are ticked, and they are shaded here as well for clarity. But this isn't clarity, it's confusion if you're looking alongside the meningococcal chart we saw before, where a tick meant one thing and shading meant something else. So please be aware, on the pneumococcal chart, listing on the left means they're eligible for the vaccine, and tick with a shading on the right, this being for children under 5 and this column for 5 and older, you need a tick and a shade for a funded vaccine. And there's even one indication, as you'll see here, if you've got very good eyesight, there's an asterisk next to this tick for chronic renal impairment, where there is a definition beyond which from one group is recommended, and you need a higher level of severity of chronic renal impairment for it to be funded. We'll come to that again in a minute. So the general changes affect everything about pneumococcal vaccination other than for children. So the recommended vaccines and number of doses for people with risk conditions, and the timing and type of vaccine, of pneumococcal vaccine, where we have recommended vaccine doses for some, but not all risk factors being funded. For older non-Indigenous adults, we have changes to which vaccine and at what age. And for Indigenous people, we have recommended changes to the recommended number of doses of vaccines. The emphasis is routine pneumococcal vaccination schedule for all other infants who are not high risk and not Indigenous remains unchanged. Just to remind you about the clinical features of pneumococcal disease, the invasive syndromes, meningitis, pneumonia and septicemia following transmission in the throat and nose. Non-invasive forms of pneumococcal disease include otitis media, sinusitis, and sometimes otitis media can lead to mastoiditis with pneumococcal disease, and bacteremia without a focus. It's caused by the bacterium called the pneumococcus. It's strep pneumoniae. The infection usually starts with a colonizing event in the nose and throat that may be asymptomatic, and many infections don't amount to anything beyond colonization, but some spread locally or invasively to cause disease. There are the non-invasive clinical syndromes and the invasive syndromes, and pneumococci usually possess a polysaccharide capsule which occurs as more than 90 serotypes. So it's pneumococcal infection is not one condition, but actually 90 different serotypes can cause it. And the immunity to the organism is capsule type specific. So that's why pneumococcal vaccination is so complicated, because of the huge range. It's like 90 diseases, but there are predominant strains. The other complicating element of clinical pneumococcal disease is the high degree of antibody resistance that occurs, where it's mainly treated by beta-lactam antibiotics and some other antibiotics. They increasingly develop resistance, and strains have become resistant to all of these common antibiotics, which really makes treatment difficult. And we also get strain replacement. So where a vaccine protects very effectively against some strains within it, other non-vaccine strain components can proliferate. So it's a moving field and a very difficult area, and that's why there are changes to the pneumococcal vaccines and changes to the recommendations, because we're dealing with a very clever bacterium. Transmission occurs through respiratory droplets, either from people with pneumococcal disease or even from healthy carriers. And if the infected person propagates in close proximity to someone else, infection can spread, and following acquisition, the bacterium becomes established in the nasopharynx of the host, and sometimes with asymptomatic colonization, where it can then spread to other parts of the body and cause disease there. Who is most at risk? These are the groups of people who suffer the worst, highest incidence and highest morbidity of pneumococcal disease. Indigenous people, young people and old people, children in group, childcare and developing countries, nursing home residents and smokers, people suffering with chronic conditions of all systems, and people with cochlear ear implants, cerebrospinal fluid leaks, or impaired immunity for any reason, both from the condition or from medication. Vaccination against invasive pneumococcal disease, well, there are a large number of different types, as we mentioned. The vaccines are designed to protect against the most common types that cause serious disease. Vaccinations routinely available under the National Immunisation Program for adults over 70 and for Indigenous children from Indigenous adults from the age of 50, and also for infants and young children on the schedule. Having a large percentage of vaccinated children in the community helps to reduce the number of invasive pneumococcal disease in people of all other ages. And due to herd immunity, where diseases have less opportunity to spread, people who are susceptible to infection are less likely to be exposed. We've had high uptake and coverage rate of vaccination for pneumococcal vaccines in children, but vaccination rates do vary from area to area. So just to show you the incredible impact of the introduction of pneumococcal vaccine just from the Prevnar 7 strain vaccine, 7-valent vaccine that was introduced in the early 2000s, and we see a remarkable reduction in infants under 1 year of age and older infants, and in elderly people. And Indigenous Australians have this continuing increased disease burden compared to non-Indigenous Australians. Hospitalisation and death rate similarly affected, and you can see we haven't impacted hugely for people over 65, even though the huge reduction in young children is apparent in terms of hospitalisation rate and death rate as well. As you can see, we're still at significant numbers of deaths. So let's now focus on the vaccines that are available, and then we'll understand the schedule and the schedule changes. So there are 2 vaccines available. One is the Prevnar 13-valent pneumococcal conjugate vaccine that's been in use in our vaccination program for children and the routine schedule age of 2, 4 and 12 months, with additional 4th dose of that vaccine recommended for high-risk children, and now routine at age 70 and for Indigenous people at from 50 and above. Our other vaccine is the traditional 23-valent pneumococcal polysaccharide vaccine, the Pneumovax 23, that we've used previously recommended routine at age 65. Now it's only recommended as a supplementary vaccine for people in high risk, and the minimum age for the vaccine is 4 years of age, as opposed to 6 weeks for the Prevnar 13. 6 weeks of age. And here are the different serotypes that the vaccine components comprise. So these are the common serotypes of pneumococcal strains that are in both the Prevnar 13 and the Pneumovax. And these are the additional serotypes that are a component of the 13 and these ones for the 23-valent. So the adult vaccination recommendations in summary are that both 13-valent and 23-valent are now recommended for individuals with certain medical conditions that we'll look at in a moment and reference in the handbook. Unless previously received, people who need pneumococcal vaccination need 1 dose of 13-valent, 2 doses of 23, and they're funded by the National Immunisation Program for the people we'll define, and for all Indigenous adults over 50. Across the lifetime, there is therefore maximum of 2 doses of 23-valent, and the minimum interval between 23-valent vaccines is 5 years. 1 dose of 13-valent Prevnar 13 is recommended and funded by the NIP for all healthy non-Indigenous adults over 70 who've not previously received a 13-valent, and very few of them will have received a 13-valent. There are no pneumococcal vaccines subsidised on the P.B.S. any longer. There was access to Pneumovax on the P.B.S. prior to the 1st of July, and that's now discontinued because of the new schedule. So let's now dissect the new schedule with that background of information and try and make some sense and categorise it to make this workable in our minds. So we're looking both at the clinical decision tree on the front page of this sheet, and we're looking on the back side for the table of recommended and corresponding columns for the funding of the vaccine. Let's start just looking at this in detail, and you can see some important elements here. Previous episode of invasive pneumococcal disease is an indication that is funded on the National Immunisation Program for pneumococcal vaccination. And remember, if they're on this chart, they're ticked, they're recommended to have, if they're on this chart, on the left side listing, then they're to have a Prevnar vaccine plus additional doses of the Pneumovax. If they're ticked, then those vaccines are all funded. If they're not ticked, then where they're recommended to have it, it's not funded. Smoking, diabetes, liver disease, these are conditions that are recommended to have vaccine, but as you can see, not funded at any age. So let's understand that the presence on this side means that the person is recommended to have it. Absence of a tick on this side means that it will cost them a private script. For Pneumovax, the scripts are around $60 a dose. For Prevnar, private script is around $170 a dose. So there is significant cost burden for people who are recommended to have the vaccine and who are not funded. So let's, if you've got that sheet next to you, keep it with you as we step through the decision tree to be able to see which category people are in. Let's break this down and make it easy. Firstly, the universal childhood schedule for people who are not at high risk, not Indigenous, it doesn't change, and it's 3 doses of Prevnar, 3 at these age points. And these are include Indigenous children living in ACT, New South Wales, Tasmania and Victoria. Indigenous children elsewhere will come into the next group. While we're keeping things simple though, let's go to the other end of the age spectrum and have a look at where there is a change. So this is now indicated at age 70, where we used to have non-Indigenous adults without risk condition being recommended Pneumovax at age 65. This has shifted in age to 70 and shifted from Pneumovax to 13-valent PCV. The green here is 13-valent PCV Prevnar. The purple is the Pneumovax 23-valent polysaccharide vaccine. So let's move on and see the next group are Indigenous adults over 50 without any additional risk condition. They have the Prevnar to start with, followed by 2 doses with those time intervals for additional doses for Pneumovax. Now looking at risk children, including Indigenous people in Northern Australia, there is an additional Prevnar vaccine beyond the 3 that are given at universal age point for children. There's the 3rd one at 6 months. And all of that is followed by 2 doses of Pneumovax at age 4 years, and then a 5-year interval for the 2nd dose. And in children over 12 months, adolescents and adults of any age diagnosed with a risk condition on the reverse of this page, they are given the Prevnar to start with, and then 2 further doses of Pneumovax 23-valent polysaccharide, pneumococcal polysaccharide vaccine at these time intervals. That is age 4 years or 2 months, minimum 2 months later than the Prevnar vaccine, and then 5 years following that dose is a 2nd dose. That's now broken down the categories so that we can get our minds around applying the high risk, and then we can make sense of the schedule. The other supportive information that isn't so clear in the charts because it's obscure is the minimum age, and we said that earlier, 6 weeks of age for the 13-valent Prevnar and 4 years of age for the 23-valent Pneumovax. Catch up for children who are not at risk, not have any indication for risk, that is, they're in category A, that first column, the universal column. Catch up continues till age 5. They don't need any further catch up once they're over 5 years of age. The minimum dose intervals are defined here, which are not so clearly apparent in the chart. But in children under 12 months, if you're giving a Prevnar vaccine following an early Prevnar, that applies for dose 1 to 2, the interval is 1 month. Over 12 months, where you're giving the interval between dose 1 and dose 2 and dose 3, it's a 2-month period. A 13-valent vaccine followed by a Pneumovax, there is a minimum interval of 2 months. A Pneumovax to a Prevnar, minimum interval of 12 months, and a minimum interval between 2 Pneumovax vaccines is 5 years. The complex catch-up for children at high risk is found in the chart in the handbook and in the guides, and it's very complex for different ages. It needs to be consulted at the time, so be aware, catch-up for children is complex. This is my summary slide of pneumococcal vaccine schedule. We've broken the back of all of the information needed to understand the schedule Without the chart next to you, it's impossible to follow. Let's have a look at how we can implement this without breaking our brains. This is just a guide I've created and we use in our practice that helps us to apply all of what we've just said. And I just break it down to 5 steps based on the past, present and future, and then record the details and update our record to complete the task. So that we don't balk at pneumococcal vaccination, let's try and make the steps as easy as possible. You can revise this yourself or whatever works for your mind or your practice, but let's step through it. Step 1 is to check the vaccination history for this individual. So I'm starting in the past. What have they had before? We can do that by looking at the Australian Immunisation Register vaccination history. And if you're fluid in doing that, you'll be able to see not just what you've given, but what other people may have given in the past. But don't forget, it's only going to be up to date since 2017, or for children younger than that, who were born from 1996. If you can access the air and identify confidently what they already have, that will supplement what you've got in your medical record. If you haven't got time to do that, check what was given in their record and ask them if they've had a vaccine recently. It's likely they will not, as an adult, have had a Prevnar vaccine before, unless you gave it in your practice or another practice has given it recently. So I then document on this sheet or in the notes the dates that the vaccines have been given in the past because they help define what future doses are needed and they help define time intervals between doses. So step 1, let's record what they've had in the past. We end up with a couple of dates on the page, or nil or unknown. Unknown is to be treated as if they weren't given. It's better to be giving extra vaccine to someone who may have had one in the past and is not aware than to assume they've had it and fail to protect them against that vaccine. So step 2, we move from the past to the present. Let's have a look at what their risk condition is. How are they placed for being in a high risk condition recommending a vaccine? So we refer to this table and we have a look and see if they're listed here. If they're listed here, then they're recommended for the high risk schedule, which is here or here. And we also check what the funding status is while we're at this point. And we record that here. I've placed that example I mentioned before, chronic renal impairment, so that we can tick the box to see whether they're not a risk condition, if their EGFR is over 30, or if they're recommended to have it by having an EGFR under 30 or stage 3 chronic renal disease. And they are funded if their EGFR is under 15. So that's pretty serious level of renal failure to qualify for a funded vaccine. And then I identify which risk condition they have and whether it's National Immunisation Program funded or not. And that helps me to guide my decision when I come up to the 3rd step. And the 3rd step is to identify which of these categories, which schedule. This is just the written for the purpose of entering in a record, just a summary chart to tick the box that corresponds to this column. A, B, C, D or E is how I've labelled it there. And it's a reminder of the different intervals between vaccine doses and how many to have. So that's just a summary of that chart that can appear in the notes with just tick boxes. And I've put that little handy guide that I mentioned earlier about minimum age, reminder about catch-ups under 5 years of age and the minimum dose intervals, just to help guide my decision at the time. Again, by referencing to this, with the knowledge of that, I then enter step 4, recording the details in the notes. And this is just a handy little summary guide of what details need to go in the notes as a very minimum and this is their past vaccines, step 1. Step 2 and 3 to combine what category schedule they're on, and what their risk condition is, whether it's funded, and what dates they're due. And then finally, to make sure I don't forget to put a recall in for if I'm not giving the vaccine today, or if after giving a vaccine today, they need subsequent doses. And that is the cheat sheet to help work through and implement without having to stumble through all of the guides that are provided on our desk. And hopefully these guides will form a reference for us, but we can simplify the implementation the way we did. I want to just remind you before we conclude with cases, some case studies, I want to just remind you of that potentially confusing chart that looks so much like the other chart. So this is the risk conditions for meningococcal, pneumococcal and Haemophilus influenza type B, HIB, for people with certain high-risk conditions as indicated here. We focused before on the meningococcal column. Here are the two charts of potential confusion side by side. So we've just spent the last few minutes prior looking at the pneumococcal recommendations on the ATAGI chart on the green schedule, and this is the purple equivalent of the green schedule, listing the recommended conditions for pneumococcal and the eligibility. Similar in appearance but different is the high-risk conditions for meningococcal, pneumococcal and Haemophilus, this meningococcal column we were looking at, and you can see the potential for confusion. Please don't mix them up. They both have a value, but I use the green chart for pneumococcal and the purple chart if I need to reference high-risk condition. Side by side, the three charts, these two on the left are the pneumococcal, saying exactly the same thing, one green, one purple, one being the National Immunisation Program chart, the other being the ATAGI chart. Separate and different is, with overlap of information but presented differently, is the high-risk condition chart that includes pneumococcal, but alongside meningococcal and HIB. So I hope that has unravelled rather than ravelled further, but let's have a look at a couple of case studies to see if we've got a grasp or not, or whether we have to start again and stay for another hour. Case 1, male, 72 years of age, non-Indigenous, no medical risk condition, no known past pneumococcal vaccination. So the easy question, which National Immunisation Program pneumococcal vaccination schedule is recommended for this person? You're right, 13-valent Prevnar is due now, and no subsequent pneumococcal vaccines are recommended unless this person subsequently develops or identifies a medical risk condition on the table on the green table that we looked at. But wait, there's more. Are the recommended vaccines National Immunisation Program funded, or will it cost them several $100s to follow the recommended advice? The answer is yes. 13-valent Prevnar vaccine, pneumococcal conjugate vaccine, Prevnar is funded on the National Immunisation Program for all people from age 70. While we're at it, it's very good practice to consider opportunity to examine other vaccines people might be recommended whenever there's a vaccine opportunity, if not to schedule a time to talk further about it. But let's consider this question. What other non-pneumococcal National Immunisation Program recommended vaccines may be due or overdue for this male at 72 years of age? And you're 100% correct, all of you who said herpes zoster Zostavax is recommended from age 70 and funded from 70 to 79, unless contraindicated by them having an immune compromised or other contraindication to the vaccine. Be aware of that potential risk. DTP booster with Boosterix or Adacel, recommended from age 65 if not previously received in the prior 10 years, and annual seasonal influenza vaccine from the age of 65 too, so check that while you're there, and that's very good practice, top marks for everybody. So case 2, let's consider his neighbour across the road, a male Indigenous person aged 45 with no medical risk condition and no known past pneumococcal vaccination. So the question is, what pneumococcal vaccination schedule is recommended for this individual? And that's 100% correct, you're right. Due a Prevnar dose due at age 50, so not due until the age of 50, followed by 23-valent Pneumovax 2 doses, and the intervals as indicated there. So this person is not indicated to have a vaccine yet, but when they reach age 50, they will. And they, of course, are that column on the chart, second from the right, on the clinical decision tree. So are they recommended, are those recommended vaccines at age 50 funded or not funded? Yes, all of those vaccines are funded for that, that individual once they reach 50 years of age. And that will be both the Prevnar vaccine initially, followed by 2 doses of 23-valent Pneumovax 23. Third case, a female, non-Indigenous, age 68, no medical risk condition, according to the table, who had a Pneumovax at age 65. Now, this will be a very common individual because we've previously, if we've been giving our Pneumovax vaccines on time, we've been giving Pneumovax to people at age 65, and this lady has had one. So the question is, what pneumococcal vaccine schedule is recommended for her? You're right again. 13-valent Prevnar will be due at age 70 as a National Immunisation Program funded vaccine, and no subsequent pneumococcal vaccines are recommended unless that person subsequently develops or identifies a medical risk condition. So therefore, this person will be due at age 70. And if she says, I want to have it earlier, that's acceptable, but it will not be a NIP-funded vaccine. So it's not contraindicated to give it early, but it's not recommended and not funded until 70. And if she does elect to have a private one now, it will cost her, and then it will cost her the amount we said, about $170 currently. So, additional question, what National Immunisation Program schedule would apply in the event this patient is subsequently identified as having any risk condition in that table 1 of the high risk conditions on the flip side of the chart of the decision tree? And if she's on that chart, then National Immunisation Program recommends 1 dose of 13-valent and 2 doses of Pneumovax. So 1 dose of Prevnar, 2 doses of Pneumovax. The Prevnar would become due now or at the time that the condition is identified. Or if you didn't know she had the condition and then subsequently learned it from the point of time that you identify the condition or she develops the condition. But there needs to be a 12-month interval following a last Pneumovax. If she got hers at 65, or maybe she got it later, that would determine the time interval. And the 23-valent Pneumovax final dose will be given in 2 years' time because she already had a 23-valent Pneumovax at age 65. And the lifetime number of doses is only 2 in total now, so we only need 2. She already had 1, so 1 more there. Final question on this case, are the recommended vaccines National Immunisation Program funded? So here, this lady, we identified a risk condition from the chart. Are the additional doses funded? And the answer, you're very, very right, maybe, or maybe not, depending on what the risk condition is. And is there a tick alongside that box? Oh, this question snuck in there. I'm sorry, that was from another questionnaire. Sorry, we've got one more question. That's not it. This is it. Final case 4. Age 62 female, non-Indigenous, no previous vaccination, but has multiple medical risk conditions, including all of these listed here. She has a lot of comorbidities: diabetes, hypertension, atrial fibrillation, coronary artery disease with 2 stents, cardiac failure, chronic renal failure, stage 3 with an EGFR of 35. She's also got rheumatoid arthritis and is on long-term oral steroids. She has severe asthma, bowel cancer requiring surgery, chemo and radiotherapy, and she smokes. So the question, what pneumococcal vaccination schedule is recommended? Easy answer. She's in a high-risk group. She's recommended to have the Prevnar 1 dose now, followed by 2 further Pneumovax vaccines with the intervals as indicated there. And the final one, 5 years after the Pneumovax. Are these recommended vaccines National Immunisation Program funded? Think about this question. Very high risk, lots of comorbidities. Every single one of these comorbidities are on that table. Answer, no. Not under the new National Immunisation Program guidelines that commenced the 1st of July. This individual has all of these conditions, none of which have a tick next to them in that column. Whilst recommended for people with any one of her above medical conditions listed, none of those conditions are eligible for NIP-funded vaccines currently. Let's hope there is some amendment in time. Thank you for your attention. I remind you to make use of the references to familiarise yourself and answer questions. Have the documents available for your practice to refer to. In the future, the PneumoSmart website will have that tool when it's completed and brought up to date, and that can help in a different way. But mainly refer to the maps, to the charts. They won't let you down, and always handy to have for whatever reason.
On behalf of Murray PHN, very special thank you for providing this important immunisation update this evening. For details of upcoming webinars, please check the Murray PHN website, and if you haven't already, you may like to subscribe to our COVID-19 updates and e-news. So thank you all for joining the webinar, and to you, Peter, thanks very much for joining us tonight. Have a good evening.
Thanks a lot for all. Bye.